All right, good evening on this really, really sunny day in Chicago. My name is Washika Torres, and we're about to get started. Let me actually share. I just realized I have to share my screen. Really glad you're here with us for week 13. I don't have sound. So, why are you not? There we go. So, welcome to Epidemics of Injustice, week 13. This semester's theme is co-disruption for collective liberation in public health. Please introduce yourself in the chat using name and pronouns. Complete the check-in form, which is a bit.ly here, or you can scan the QR code. They're also in our other videos as well. During the presentation, please put questions or comments in the chat, and there will be time for questions at the end. Here we go. Here is how to use the Zoom controls, the mute button, the start video button if you wish to share your face, and opening the chat to see comments or questions or respond to others. I am the course instructor, Washika Torres, and then there are also the teaching assistants, Katie O'Neill and Nanda Nisara. This annual course is free and open to the public, and it prepares public health leaders and community members with the tools to bring about social change and address structural determinants of health. All course meetings will take place virtually, and the course is open to students and the public from 5:30 to 6:30 CST. And then students taking the course for credit stay from 6:30 to 7:30. For a closed discussion, Epidemics of Injustice is sponsored by the Collaboratory for Health Justice at the USC School of Public Health. And we'd also like to thank Radical Public Health for the creation, support, and promotion of this program. RPH is celebrating its 11th year. For more information about RPH, please visit facebook.com/Radical Public Health. Content warning, today's lecture may contain material that might be too difficult to discuss. Please step away if you need to take care of yourself during the presentation. The Collaboratory for Health Justice acknowledges that the University of Illinois Chicago resides on traditional territories of the three Fire peoples, the Ojibwe, the Ottawa, and the Potawatomi. Purchased after 2.5 years of open warfare, decades of violent encroachment, and the defeat of a pan-Indian movement to keep settlers out of the Great Lake region at the Treaty of Chicago in 1821, receiving their final payment before moving westward in 1835. The area was also a site of trade, gathering, and healing for more than a dozen other Native tribes. The state of Illinois is currently home to more than 75,000 tribal members, and the Chicagoland area is currently home to one of the largest and most diverse urban Native communities in the U.S. Illinois is also the territory of the Ho-Chunk, Miami, Anoka, Menominee, Sac, Fox, and their descendants. By making a land acknowledgement, we recognize that Indigenous peoples are the traditional stewards of the land that we now occupy, living here long before Chicago was a city and still thriving here today. As we work, live, and play on these territories, we must ask what we can do to right the historic wrongs of colonialization and state violence and support Indigenous community struggles for self-determination and sovereignty. Here are some community guidelines. Please show up on time and come prepared. Please let everyone participate. Listen with an open mind. Have mutual respect and appreciation for one another. Respect privacy and personal information shared during class. Thank you. So this week's theme is Abolition, Alternatives to Policing and Community Organizing with Dr. Arturo Carrillo. So Arturo Carrillo, PhD and LCSW, is a licensed clinical social worker and director of health and violence prevention at Brighton Park Neighborhood. He has led the collaborative for community wellness to research and document the inequity of access to quality mental health services throughout low-income communities throughout the country, and advocates for the creation of a citywide nonprofit crisis response program grounded in an expanded, publicly operated mental health system in Chicago through the Treatment Not Trauma campaign. Stop the share and welcome Dr. Carrillo.
Hello, everyone. Well, thank you for having me. I am still excited about Tuesday's results. So just a disclaimer, I am going to bring some very positive energy into the conversation today. I feel like it's the first time I'll be able to give this conversation with some real hope that we can really implement treatment not trauma the way we've envisioned it. So just a quick scan of the room. I'd love to get a sense of who knows about the Treatment Not Trauma campaign. So if you've heard about the Treatment Not Trauma campaign, by all means, reply with a yes or a no, or maybe so in the chat. Asha, I know you have. Nice seeing you. Okay, so it's a bit of a, okay, so there's a few yeses and a lot of no's, some more yeses than other spaces I've shared with folks. All right, so I love that there's a lot of yeses in this chat. And honestly, like this conversation that we're sharing and I'm here to represents a whole group of people throughout the city have gathered around our cause to establish treatment not trauma as a policy here in the city of Chicago. So for those of you who are familiar with it, by all means, contribute to the conversation in the chat. Give feedback as I'm presenting, add to what I'm sharing. Again, this represents the work of many people. And for me, it's been an honor to have been able to carry this work since 2016. By way of introduction, my name is Arturo Carrillo, lifelong Chicagoan, born and raised on the south side, the southeast side of Chicago. And I'm a licensed clinical social worker. I've been a clinician who's offered free mental health services. As a clinician, as somebody who's been working in a nonprofit area, thinking about how mental health access can be increased for communities who need the resources the most, right? So the most vulnerable, most exploited community areas of Chicago are often the ones who are seeing the least access to mental health services. Areas of the city that have the highest rates of PTSD and experiences of trauma are also the parts of the city that have the highest rates of police and policing, and investment in police seems to have gone accepted by the political landscape for decades. And so part of the Treatment Not Trauma campaign has been about remapping what our investment in resources looks like in order to benefit the most people in the best way possible, in order to prevent the expansion of the carceral state, right? So we want to really think about mental health access as a public health issue. And so, yeah, so, absolutely, I do introduce myself as a lifelong Chicagoan, and that's because the politics run deep in Chicago, right? And I don't have to really spend much time, I'm sure, as you all know, change doesn't come easy in Chicago. And so being part of this campaign has been, for me, thinking about my role as a social worker, one who can support in the process of healing for individuals who've experienced trauma, but also as a social worker, thinking about what we can do to improve access to care by changing systems, right? So I've been able to, I've had the privilege to go back to school and finish my studies and pursuing a PhD. My intention to pursue a PhD was to be able to understand the tools of research, to bring that research back into the community where I dedicated my time as a clinician, offering free mental health services through the nonprofit system, realizing that we could never offer enough services in a nonprofit system, because every time we'd expand our mental health program, we would only expand our wait list. There was more and more demand for mental health services, right? So as a researcher, at some point, being part of the Collaborative for Community Wellness, we started thinking about how research can be a tool for organizing. How can our research document how inequitable access to care is in Chicago when it comes to mental health access? And for us, really thinking about intentionally, how do we then use that research to support and drive organizing in order to reform the policies of the city that have been established to create this inequality? So I'm going to get into the data. I'm going to share a presentation and definitely have a lot to share with you all today. So by all means, feel free to add to the chat and by all means, throw your questions in there that I hope we'll have enough time to address. So I'm going to share screen and then we'll get into this. Hola, Dolores. Gusto verla. Hola. Bueno, so empecemos la presentación. We're ready to start the presentation. So as I was mentioning, as a clinician, part of my understanding of mental health access came through understanding what people's main presentation of mental health concerns are when they are seeking out services, right? So I was able to be on the front line as a provider, as a program manager, to provide mental health services, and I'd see a pattern. There was always a pattern, right? People were calling for all sorts of different reasons, But underlying a lot of the reasons that they sought out services was trauma, exposure to trauma. So for me, you know, thinking about our work as a clinician, I was really thinking about how is it that we could provide free, high quality, long-term, trauma-informed clinical services that can really address people's underlying experiences of trauma, both experiences of acute trauma, but also complex post-traumatic stress disorders, as a lot of people in the community we were serving on the west side and the southwest side of Chicago were experiencing. So for me to understand the issue on a local level also meant I needed to step away and step back as a researcher and think about it as a portion of the city. We did an assessment that surveyed nearly 3,000 residents on the southwest side of Chicago. All of the research that I'll be mentioning today is accessible to you. Anything you'd like to read up on in regards to any of the research I'm going to share with you today is on our website, collaborativeforcommunitywellness.org. So feel free to reference our webpage to find any of the research and read more details about the surveys that I'm talking about. So when we first started it on the southwest side, we were able to find a rich amount of data to address both an understanding of what the needs are for mental health services and what the service barriers are. In 2020 and 2021, we replicated this survey citywide. So we did a citywide assessment that was able to capture what the mental health needs were of residents. I'm going to present this as a slideshow. Can everybody see the slides? That's still visible, folks?
Yes.
Yes. Okay, great. So in 2020 and 2021, this is again at the height of the pandemic, we were able to assess citywide what the mental health needs were of residents throughout the city. We captured about 45 of Chicago's 50 wards. You can see the demographic breakdown here. And we really wanted to get a snapshot of what the mental health concerns were. This is what survey respondents told us. The large majority, over half, were dealing with either self-reported anxiety symptoms or self-reported depression symptoms. A third of the respondents, for the first time in the time that we've done the survey, reported having traumatic symptoms, right? The idea that they're understanding that trauma is causing a personal harm and emotional distress, right? So thinking about these findings, we think about how large of how big of a portion of the city is experiencing anxiety and depression. Again, this is at the height of the pandemic, but for us, it really was telling a story of how overwhelming the need is. Again, as a nonprofit provider with a 6 to 8 month wait list, you know, it was clear to me that definitely the need was there. But as a researcher, I really wanted to be able to quantify what that looks like. And this data set gives us a lot of information to point to. We asked the follow-up question to survey respondents, would you consider professional counseling services, right? We acknowledge that people find mental health support in many informal ways, through their social networks, through people in their lives, faith leaders, spiritual leaders, who can provide that support. But we really wanted to get to an understanding of what the willingness was to access mental health services, access mental health services from a professional therapist, right? Not to invalidate the supports that other informal supports provide, but really thinking about, is there a desire to seek out professional services? And what we found was almost all of the respondents, 94% of Chicagoans said that yes, they would be interested in seeking out mental health supports. Now, I can't think of another research question that I could have asked that would get 94% of Chicagoans to agree. It really was striking to see just the level of desire for mental health services. For the first time in this survey that we did, we asked Chicagoans, would you be interested in seeking out professional mental health services from the city's public mental health centers? And what we got as a response was yes, overwhelmingly, 90% of respondents were very much willing to seek out services in a city run, and emphasis here on the word city run. We know that the private sector, the nonprofit sector, right, the health system also can provide mental health services, but we really wanted to know what people's level of interest in public mental health services was in the city of Chicago, and this was really telling for us. We also followed that question up by asking people if they were even aware. I mean, do people even know that these public mental health centers exist? Back then, only 27% of respondents said that they do understand, that they do know that these centers are a resource for them. That's big, right? That's a significant. Only a quarter of Chicagoans actually know that the public mental health centers are there as a resource, right? So, it was very important for us to ask that question, because if you hear messaging from the Department of Public Health, they'll say that their own clinics, the public mental health centers, are underutilized, right? And so that leads to often an assumption that then the public mental health centers are not necessary because they're being underutilized, quote unquote. What our survey shows is that actually it's not that they're underutilized because there's not interest for receiving services from the public mental health centers, but they're not receiving services in many cases because they don't know that they exist and that it's an available resource. The next question we asked, and this was also very intentional. We really wanted to unpack this narrative that the city kept pushing, and this current administration pushes, that if we continue to privatize, if we continue to invest public money into private providers, the mental health centers that are in operation through the nonprofit sector, or also FQHCs that also provide mental health services, that would provide enough coverage of support for communities in high need. What we found based on our survey was that actually was not the case. After a year of implementing increased investment in the private sector, only 14% of Chicagoans said that there was enough mental health services available in their neighborhood, right? So it's really important to think about how access looks. What are the barriers to access? And here's where we asked respondents to check all that apply. We really wanted to know from Chicagoans, what is prohibited? If there's so much interest in professional mental health services, what's keeping you from accessing those services? And 68% of respondents, which is not surprising, we have had this level of response in previous surveys. Nearly 2/3 or over 2/3 of respondents said that cost was the biggest prohibitive barrier, which makes sense when therapy can range, the cost for therapy out of pocket can range anywhere from $40 to $160 an hour per session, right? So cost is a very much the prohibitive factor. If you compare that with stigma, right, this idea that people wouldn't seek out services because of stigma, what we're seeing is that only 11% of respondents are saying that stigma is access barrier for them. By comparison, we see that insurance, or the lack thereof, not knowing where to go for services, or services are not available in your community, or not available at convenient hours, are bigger barriers in our data than stigma, right? So this is very important. So, here we go, right? We were able to use research to identify both the needs for mental health access, but also what the biggest barriers are. And so for us in this analysis, and it's very much part of the conversation that I'm really excited to get into with you all today, as you all, I'm sure, have discussed what structural violence looks like, right? How is it that systems can and are created deliberately to exclude people from access to care, and create ease of access for certain populations, right? Our research was very important because we really wanted to place it within the political and social context of Chicago. Of course, access barriers to mental health are very much an American problem in a society that does not believe in access to universal health care as a human right. What we really wanted to see through this survey is to understand how the inability for people to access mental health services is very much by design. What we were able to see, of course, is that in Chicago, the areas, and this is reporting from 2015, but this data has been very much consistent throughout many, many years. The areas that have the most 911 calls for mental health services are also the areas of the city that have the fewest services, right? And again, that's not necessarily, it's very intuitive to think about the problem that way. But when we really map out the issue, what we're seeing is how a system has been created that can create an abundance of access to care in certain parts of the city. 21% of Chicagoans live in areas of the city that you see here on the map, as highlighted in green or dark green, that have an average of 4.3 therapists per 1,000 community residents. That's an enormous disparity when we think about the vast majority of Chicagoans on the map you see shaded in yellow, areas of the city that have an average of 0.2 therapists per 1,000 community residents. Again, we see areas of the city, the most affluent neighborhoods, have the highest access of care, where the highest economic hardship community areas of the city, those areas of the city that have highest rates of violence and poverty, are also the areas of the city that have the least amount, and in some communities, actually zero therapists per 1,000 community residents, right? So we really think about how, unfortunately, we live in a city, and it's very much a divided city of the haves and have-nots, and that is very much by design. And I could say that as a clinician who has this LCSW, there are many clinicians in Chicago that are bicultural, bilingual, but they're operating in very select parts of the city. And that is because of our capitalist system that allows for access to care for those who have the means to pay for it out-of-pocket costs, or who have expensive or employer provided health insurance that provides access to care for those individuals, and not for people on public who have public who have healthcare that does not provide access in areas of the city where we're seeing, again, the lowest rates of care, right? So, you know, our research, and this is a study that we've released recently, has also captured what, for me, is a perfect illustration of what disinvestment and the impacts of disinvestment look like in Chicago. What we see on this map is the highest rates of 911 behavioral health related calls. So this is when someone calls 911 for a mental health concern. We see that in this 2-year span, 3-year span, we're seeing Chicago's 50 wards broken down by highest rates of 911 calls for mental health concerns. What you see also on the map is an overlay of where Chicago's 19 public mental health centers at one point stood. Every X on this map is an indication of every public mental health center that has been closed, not just by Rahm Emanuel, but also by Mayor Daley. The 5 dots that you see on the map are where the 5 public mental health centers remain. And again, the areas of the city are very much correlated. They have the highest rates of 911 calls, are very much correlated with where in the city the public mental health centers have been closed, right? So once again, residents from those parts of cities at one point in time had access of readily available for mental health services in their own neighborhood. And now, because those supports have been removed to save a tiny percentage of money from the city budget, we see now an over-reliance on police to respond to mental health concerns, or medical responders, right? I won't get into that as much now, but I do want to do a quick breakdown of what that actually looks like in our city budget, right? So this is from budget expenditure figures from 2017. What we're seeing is that the police department in 2017 received nearly $1.5 billion as part of the operation budget for the police department. What you see on this map, on this diagram here, is public health, the Department of Public Health budget in 2017 was only $32 million. Again, this is the portion of the budget that Mayor Rahm Emanuel was looking to extract savings from when he closed 7 of the 12 public mental health centers. Again, the budget for police has increased year after year since then. What does that look like in comparison side by side? This breakdown shows that for every dollar in 2017 we were spending on policing, we were only spending 2 pennies on the Department of Public Health. Again, the Department of Public Health has a lot of responsibilities, among them to provide public mental health services through the public mental health centers that they operate. You know, one of the things that one of the arguments is that if Chicago is so violent, right, investing in policing can address the issue. Well, what we've seen is that actually crime indexes have not necessarily continued to rise. What has continued to rise has been the investment in policing. actually, this diagram, I don't have that slide. There's another slide that I'd like to share at some point, but I don't have it in the slide set. Shows that in the same time period that you see here, the investment in policing has tripled. There has been a 300% increase adjusted for inflation per capita. We spend 3 times more now in police than we spent in 1965, right? So we think about the investment in policing continues to go up year after year. And what that's created is a system that continues to incarcerate individuals who have mental health crises, who have mental health concerns. What we have now as a result is Cook County Jail being the biggest mental health provider for mental health supports, if you could call them that, in Cook County Jail, inside the prison. We also have very horrific situations in which police violence has ended the life of people who have had mental health crises, a long list to name, but here's a few examples on this slide here. When we talk about public safety, right, Chicago sees public safety through this lens that continues to see police as the providers for public safety. We have over 14,000 police officer positions of the 20,000 public safety positions. Of those 14,000 police positions, 13,000 are sworn officers, right? We currently have only 90% of those positions filled. So we have over 1,000 vacancies in the police budget. What we have remaining is only 3.4% of our corporate fund going into community services, which includes public health department. In other words, we only have 20 therapists funded by the city, while we have 14,000 police positions funded by the city for public safety, right? So we really have to think about that disparity as a political decision, right? It very much is what our political policies have been up until now in the city of Chicago that has continued to reinforce increased investment in policing, to the point that now we are investing $2 billion of our city budget into policing. When you include police overtime and police lawsuit settlements, we actually are paying closer to $3 billion of tax dollars to police. With that amount of investment, if policing kept us safe, we would be the safest city in the world. And so again, it's very much maddening to think about how we continue to invest in policing as a sole way of addressing public safety, and continue to do so time and time, year after year. So where does that take us? When we think about the Treatment Not Trauma campaign, and I'll shift gears now to talk about what our proposed Treatment Not Trauma campaign brings into the conversation. When we were assessing the city budget and thinking about where and how we can reopen public mental health centers, we were pushing for the reopening of the public mental health centers by asking for at least $25 million to be reinstituted into the Department of Public Health to reopen public mental health centers. We have an administration now, the Lori Lightfoot administration, that has been adamant that she will do everything possible to not reopen public mental health centers. And so when we realized that this administration was absolutely not going to budge on that topic, we started looking at what other cities were doing to address public safety by investing in mental health access for people who need care in communities. And what we found was a model of care in Eugene, Oregon, that was called the Cahoots model. It's called the Cahoots model, that sends a paramedic and a paramedic and a social worker to respond to mental health crises instead of a police officer. We saw this as an opportunity to think about how public mental health services and public safety can be intertwined in such a way that we can respond to crises in community without police. And so we really look to Eugene, Oregon, to think about what alternatives to policing can look like. And so I want to share this video. I want to play this video for everyone here, and I want to get a quick reaction from those in the chat. I'll be reading through the chat while the video plays, to think about, is this a model that you see could be viable for Chicago? Do you see this as a model that could that can benefit people in our communities here in Chicago. So I'll play the video and I'll be watching the chat while this plays.
Today, across CBS News, we've been taking an in-depth look at America's mental health crisis. We call our initiative Stop the Stigma. Nearly 4 million people in this country with severe mental illness go untreated. They are 16 times more likely to be killed during an encounter with police. Omar Villafranca shows us how one city is trying to change that.
There's a guy on River Road who I think would benefit from having Cahoots come visit him.
When a mental health-related 911 call comes in,
Royal Avenue.
a specialized team in Eugene, Oregon rolls out.
Pretty much everybody we see is, for one reason or another, in a state of crisis.
Manning Walker is a medic, and Laurel Lisovskis is a mental health crisis manager. The pair are members of Cahoots, crisis assistants helping out on the streets. They answer calls like suicide interventions and overdoses. They're unarmed and most of the time without police backup.
We always move as a team. Whoever is talking and making contact, the other person is observing.
They took our CBS crew on an exclusive ride-along. Their first call was for a woman they'd met before. They believe she's schizophrenic. She told us her name was Kayla.
Would you rather deal with someone with Cahoots or like a uniformed police officer?
Definitely Cahoots.
How come?
They don't, help you when you're in the time of need or when you're hungry or certain things like that.
Cahoots was founded in 1989. Last year, they responded to nearly 23,000 calls in Eugene and Springfield, Oregon. Denver is starting their own version of Cahoots. City leaders from Oakland, Olympia, Washington, and even New York City are all considering similar pilot programs. Tim Black is Cahoots operations coordinator.
We handle almost 20% of the entire external public safety call volume for our area. But there was such a dramatic need coming in through the 911 and non-emergency lines that there was a need for there to be this kind of behavioral health first response.
Let them know that you're out of your bed.
Cahoots team members are trained to de-escalate when responding to a mental health crisis.
Thank you guys so much.
A recent study found 25 to 50% of fatal officer-involved shootings involve someone with a severe mental illness. Eugene's police chief, Chris Skinner.
They don't need jail. What they need is they need to be able to be de-escalated from their crisis. They need a ride to a mental health facility or to a medical care facility or wrapped around with services. That's what the people need. They don't need to be going to jail every time.
A new way to protect and serve, and maybe save a life. Omar Villafranca, CBS News, Eugene, Oregon.
And there is much more CBS News.
So, yeah, this was our proposal when we introduced the Treatment Not Trauma Council Order back in 2021. Sorry, the years kind of blur together. So when we were introducing the Treatment Not Trauma Council Order, we were calling for a non-police crisis response to be established. What I'm seeing in the chat is people are mentioning and referencing the CARE program. And I'm happy to talk about the CARE program because when we introduced our Treatment Not Trauma Council Order, Mayor Lori Lightfoot was calling for a police-driven crisis response program to be established, which is called a co-responder model. A co-responder model establishes a crisis response team that involves a police officer and a social worker responding, or a paramedic, a police officer and paramedic or social worker to respond to mental health crises. When we presented the Treatment Not Trauma Council Order, Mayor Lightfoot took to the bully pulpit during her budget address to essentially ridicule the possibility of having non-police crisis response in the city of Chicago. She made this argument that Chicago was somehow different and a crisis team that did not involve police officers could not be a feasible idea in Chicago. So there was a great amount of pushback when we introduced the Treatment Not Trauma Council Order in City Council. Alderwoman Roxana Rodriguez Sanchez, who has championed this in City Council, introduced the council order with the full support of our coalition. We co-developed that council order and called for a hearing on the matter. This administration took tremendous amount of political pressure to not let that council order be introduced into the health committee, to not have that hearing held in the health committee. What followed was public pressure and our campaign and organizing efforts to push aldermen to step up and be able to advocate for a non-police crisis response to be established. What that ended up leading to was a concession and a compromise that was not done with our authorization as a campaign, as a coalition, but happened nonetheless, which now established one pilot team that was a non-police pilot team to be piloted, that was added to the mayor's proposed 2 pilot teams, 2 co-responder teams that were to be piloted in 2021. So what we were able to gain was one non-police pilot team to be established in the city of Chicago. Subsequently, there was also a second non-police team that was to be established. So there was a total of 4 teams that were now going to be piloted in Chicago. 2 that were co-responders and 2 that were going to be a non-police response. Now, why is that important? One is because we pushed the envelope in Chicago to establish non-police crisis response. This administration is taking credit for establishing this, but that is very much not the facts. And there's a lot of articles I could definitely share if people are interested in knowing how we were able to gain non-police crisis response as a pilot here in Chicago. Why it also mattered was because other cities were also toying with and experimenting with different forms of crisis response. New York City, for example, also was piloting both a non-police response and a co-responder response model for mental health crises. And what they found in their pilot was that there are some real concerns with the co-responder model. And so I'm going to share a video that highlights what happened in New York.
Across CBS News, we've been taking an in-depth.
Can people see this second screen that's opening up? Is that visible?
Yep.
Yeah.
Okay. So again, I want to share what New York City found when they were piloting this co-responder model, which again, this is very much how Chicago has developed crisis response. We have FOIA'd, we have definitely been able to get information after filing a lawsuit against the city for prohibiting access to FOIA material that we were trying to gather from 2020 when we introduced our treatment on trauma council order. And what we were able to find after accessing a request for FOIA information from the Department of Public Health was that the city's current care program has been very much defined from the start by the police department. It is a police-driven model. And so what we have here is an example of a different model, one that was established as a pilot in New York City that was very much also a police-driven model. And I want to show, and I do want to give a quick trigger warning. If people are triggered by police violence, please step away. I want to show this video to highlight what happened in New York City.
The I-Team is taking you to the front lines of New York City's newest effort to reform policing. And that question, should police be the ones to respond to 911 calls about mental health emergencies? A new pilot program is about to send EMTs out with social workers instead of officers as they answer the call for change. Now, there's a range of reaction from optimism to safety concerns with this. Let's go to the I-Team's Melissa Russo with the exclusive.
No, y'all can't break my door. Y'all not gonna pay for it. You're not breaking my door.
Peggy Herrera called 911 because her son needed help.
He was having a crisis and he locked himself in the house.
Peggy was afraid of what might happen if police showed up.
I need the ambulance to show up first, not the police.
EMTs arrived with police who could see her son through the window.
He's fine. He's there. You can see him. He's not bloody. He's not nothing.
But the situation went south.
No! Stop! Stop!
They grabbed him by the neck, pulled him down, beat him up. He never got the help he needed, and I spent the night in jail.
Encounters like these are why many are calling for police to be removed from responding when someone calls 911 about a mental health issue.
So you heard that, you heard correctly. The mom was calling for a mental health emergency for her son, who specifically requested not having police show up, ended up spending the night in jail, and her son was assaulted by the police. This is the dangers of the co-responder model that this mayor and this administration has continued to push forward as their sole option, as a police-driven model that they've been able to push forward and label now the CARE program. This is very problematic, as you're seeing, of course, not only because of the dangers it presents, but also how wasteful the resources that we continue to invest in policing go when we really think about how and what supports people in need in communities. This woman and many people in Chicago want non-police crisis response as an option. She specifically requested that. The city of Chicago is piloting the CARE program that is not giving people the option to have the option for a non-police crisis response team to respond. Even in the one police district where the crisis response team, that the non-police crisis response team is in operation, even in that one district, if you call 911 and you happen to call during the 10 to 4 p.m. work hours of that one pilot team, if you call, you cannot request that one pilot team to show up to your mental health crises, right? So part of the problem here in establishing this CARE program is that the city is giving people a false narrative that they are doing something different, when in reality, as we saw in New York City in this video, police still very much are part of a mental health crises. And in this case, you saw an example that led the city of New York to establish a non-police crisis response program citywide for all of its residents as a result of what they saw in this video. Chicago has yet to learn that lesson. We still have an administration who's pushing for a police-involved crisis response system in Chicago. This is a quick outline of what the mayor's initial plan was, as I mentioned. There was a co-responder model developed by the police department. And there was no commitment to expand operations of the public mental health centers, right? This is what other pilot programs look like in other parts of the country. The city of Chicago ended up expanding that initial pilot that I just shared because of our campaign to establish the 2 additional teams that increased the investment to $3.5 million for that initial 1-year budget. By comparison, you see smaller cities invest way more in their pilot programs, establish way bigger programs, as in New York City, which was able to expand the non-police crisis response program citywide at a cost of $112 million. This is what real investment looks like to create these alternatives, alternative models of care in other cities when there is the political will to do so. We have data that shows from other cities like Denver, for example, Albuquerque, and other cities who have expanded non-police crisis response. In this specific data set that we have here, this was part of the findings from the 6-month pilot program in Denver for the non-police crisis response. The subsequent year-long pilot data showed the same data results that we see here, in which of all the service calls, 0 required police backup, right? So we have examples in other parts of the city that non-police crisis response can be done without police, can be done safely, can make sure that everybody receives the support that they need if the proper infrastructure is in place. I was able to see in the chat, there's comments around the city's quote unquote investment in all 77 community areas. I do want to highlight, as one of the people in the chat commented, that yes, absolutely, there may be increased investment from public money into the private sector, but that has fallen way short and does not actually provide, in many cases, additional resources. It funds the existing system that already is there. What the city then does is take credit for the FQHC that received funding for the people that walk through that clinic to then generate numbers that can say that the city has now served quote unquote 60,000 people or provide 60,000 services of care, units of service of care, which we again are looking for an explanation of what units of care look like. What we see then is that what the city has done is it's chosen to not provide the services themselves by increasing the public sector, and instead has become reliant on a system of care that is not adequate, does not provide decent salaries and wages for its workers, as we've seen most recently with the Howard Brown workers going on strike to increase wages and improve their working conditions when providing mental health services to people in high need, right? These are issues that we unfortunately continue to deal with in the private sector in spite of what the city claims credit for by giving small grants to mental health providers who are already stretched thin and have extremely long wait lists in most cases. We choose to fund policing as our sole public service in Chicago, or our biggest public service in Chicago, paying officers starting wages of $82,000 a year with full benefits and pensions. Right, we choose to hire 14,000 police officers and only 20 therapists. One of the things that we found throughout our investigation, as other cities are rolling out non-police crisis response programs, we find that their programs are often running into the same issues that we, of course, see here in Chicago. Chicago funds these quote unquote trauma-informed centers of care through ARPA funding that will expire in 2 years. To provide quote unquote additional services. However, one thing that they do not mention is that those services are not actually being coordinated with the care program that the city is actually developing. So when crisis response happens, there is no coordination of care to the private sector to actually have crisis response provide follow-up care to individuals in a way that can be tracked and monitored and be able to provide the follow-up care that's necessary to people in mental health crises. That would be possible if we were able to expand the public mental health centers to have those centers serve, as you will, as a home base for crisis response workers to also then be able to provide the case management and mental health services that would be necessary for people to receive ongoing care after crisis response has presented itself. What we have instead is a crisis response program that has no infrastructure, no public infrastructure to provide the coordinated care that's necessary for people who have dealt with crises. So once again, as we mentioned, we've introduced this council order back in 2020. We did not have a hearing. In 2023, we introduced a budget amendment calling for, remember when I said that there was about 1,000 vacancies? We called for an immediate transfer of funds in the 2020 budget to shift 200 of those vacancies. That would still allow for 800 police vacancies to exist. We would transfer 200 of those vacancies to immediately stand up an expanded public mental health system that could fund mental health providers to be part of crisis response, non-police crisis response teams, as well as having mental health providers in communities receiving good salaries in public mental health centers to provide the follow-up care that's also necessary to address crises. So by way of comparison.
Sorry, we're just going to have to make sure.
I'll wrap up quickly. By way of comparison, the public mental health center pays its employees, just so everybody knows, and this is why the private sector is very problematic. The private sector defines wages for workers. Oh, sorry. All right, last point then. The nonprofit sector pays its therapists around $40,000 a year on average. The public mental health centers pays its employees $77,000 a year plus benefits and a pension. So for us, the investment in the public sector could create the sustainable long-term job opportunities for therapists of color, therapists who are culturally appropriately trained to serve communities in high need, to have benefits and employment opportunities to be able to give back and provide the services that are desperately needed. So I'll stop there.
Thank you so much. So we are going to have time to take about maybe just one question from the audience, and then we can look to the discussion board and the chat for questions as well. So does one person want to come off mic, ask their question? I
can ask mine.
Yes, thank you.
Dr. Carrillo, so what can we do as people who, are working in our communities, who really care for our communities and are working with the health department or nonprofits that have federal grant money that has a lot of requirements? What can we do to push for real social change that's not just more social service that's just kind of, putting a Band-Aid, on a gunshot wound?
Yeah, you bring up a very important question, and I'd like to talk about it for an hour. but I only have a few minutes. I mean, I just to keep it simple, I feel like when we use about 40% of our discretional spending on policing in Chicago, it allows for little else to be offered to the residents, to, as you're pointing out, to address issues that don't necessarily always have to be dealt with by therapists, right? But we can't think about these alternatives when we, again, continue to use 40% of our discretional spending on policing, right? So, you know, I know there's a lot of pushback when people say defund, but really what we're thinking about is how we prioritize spending to make sure that we continue to find different ways of engaging people and supporting them to respond to their needs instead of only investing in policing as the option.
Thank you.
Thanks. So we have one more question we can take from Vanessa. Would you like to unmic and unmute your mic?
Yes. Hi, Dr. Carrillo. I have a question. So I'm actually going to Springfield on April 18, and I might meet a senator and a representative for one of the communities that we serve. I would love to have maybe like a flyer or something that I can talk to them about, because I have an agenda as to what we're going to talk to them about, what services we want them to allocate funding for. And I would really love to talk to them about this statistics and see if they can lobby for mental health for the city of Chicago and the residents that we're serving.
Absolutely. Well, Vanessa, my information is on the screen, so feel free to follow up with me with an email. I will say we introduced a council order also because the Department of Public Health chose not to pursue state funding that would have allowed for the expansion of 988 by way of the Department of Public Health. They purposely, and this is a conversation we had with Matt Richards, Deputy Director of Behavioral Health, who chose to not apply for state funding to create those systems of care here in Chicago by way of the Department of Public Health. They very much wanted to abdicate their responsibility to the private sector. So I'm happy to share information with you, but a lot of the decisions that are made around this issue have been in the municipal government, not state government, because the state has been putting out funding for this. It's just that the city's choosing not to see its role in providing these services.
But I think it's still important to talk to them about this, because I work in the field of early childhood with Lurie's, and we are seeing a lot of like correlation with like sexual abuse and like child maltreatment, because families are suffering from lack of mental illness support. So I think for me, it's like something that we can
absolutely
connect to early childhood development.
Yeah, absolutely. Well, Vanessa, feel free to follow up with me. I'm happy to talk to you more about that.
Thank you.
Thank you.
Thank you so much. And so we're also going to take a question from the other chat question. So someone was wondering, whereas I guess if any impact, or what impact, if any, has the 988 helpline made a dent? So what kind of impact has the helpline made?
Unfortunately, it's not a coordinated system, 988. For example, the South Side of Chicago does not have a 988 response system provider yet. The North Side has C4 as its 988 provider. But still 988 does not, if you call 988, you're not going to get a crisis response team to support you as it stands today. So our fear has been that those 988 calls then end up being deferred to 911 when crises are not being able to be handled over the phone. And then of course that would elicit a police response. So that is the real concern of this system. The state funding that I was referring to earlier, that the Department of Public Health could have applied for, would have allowed for the Department of Public Health to be paid for managing and establishing crisis response through that 988 system, and they chose not to.
Okay, thank you. And so someone also said it's kind of this comprehensive, I guess the envision, this comprehensiveness to this movement was that there also needs to be an increase in psychiatric beds and physicians. And are there any movements for that? Or I guess also, could you expand upon your ideas within that regard?
You know, we did contribute to that piece that was shared in the WBZ. Actually, the person that was highlighted in that, sharing her story about mental health crisis for a young person, came from a community forum that we were holding in Brighton Park as the work that I do with Brighton Park Neighborhood Council, to hear about parents' concerns when it came to the SAS system. And so the reporters were there with us 2 out of the 3 days, listening to testimonies from community residents. Yes, the WBEZ story did highlight the need for more beds, and that is absolutely true. However, what the story left out was how every one of the parents who was also in that space wanted to make sure that there were enough resources available before crises require hospitalization to be able to provide support to prevent hospitalization from happening, because hospitalization in of itself is also harmful and can be very problematic for young people who are having mental health crises. Every one of the parents in that room, again, the part of the story that they did not cover, was calling for increased investment in public mental health services and community resources to prevent crises from escalating to the point that young people are required to be hospitalized. So again, yes, there is the need for more beds, but if we could also do a lot more prevention, there wouldn't be the need for those beds in the first place.
Yes, and I do also want to add to anyone to research the ADA Parks project, ADA-PARC project. It's a project that's been going on for about 20 years. And statistically, you're right. Most people who are in these kinds of settings actually need community support, which was proven with the, my goodness, I'm sorry. It was after the ADA. It was... it's fine. It slips my mind now. But so most people who have certain crises or disabilities actually benefit more from being in the public rather than being in these kinds of institutional settings.
Absolutely.
And so I just wanted to also point that out, that, yeah, you're right. More community investment is needed to prevent people from needing those services. So not just people with mental illnesses, although there are certain rulings about them as well, people getting more, people being reintroduced into the community rather than in, nursing homes, which actually have a lot of disabled people rather than people who are elderly. So I'm so mad that I can't remember the name of it's on the tip of my tongue. And so the last question was, how do you envision your organization working with the new mayoral administration that starts next month?
Well, I'll go back to the slide that I didn't get a chance to go to. I think this speaks for itself. Paul Vallis versus Brandon Johnson was captured as more beat cops versus treatment, not trauma. It's his campaign promise within the first 100 days to implement treatment, not trauma. So we are very excited for Mayor Brandon Johnson to take office.
So also, it was the Olmstead Act. Sorry, it was the Olmstead Act because 2 women who were disabled and had other types of disabilities were put into institutions and they do not have to be. So to answer that question, so I just wanted to make sure that was also mentioned, because that is my field as well, disability studies. So that was what it was. But yes, thank you so much. I'm glad that you're, obviously optimistic about this administration. I think there are many people who are. So yeah, thank you so much. And I'm going to stop the recording.